So all surgeries have risks, and we do knee replacements and knee surgery for pain relief and improved function, but surgeries do have risks. And the standard risks apply with the knee replacement as many surgeries. Infection, bleeding, blood clot, nerve or blood vessel injuries, extremely uncommon with the exception of numbness around the scar. The possibility of needing a blood transfusion, in our experience, is very low after a knee replacement. About 2% of our patients may require blood transfusion after a knee replacement. Those are usually patients who start with a lower blood count initially. We typically do not recommend patients donate their own blood preoperatively anymore. The possibility of a blood clot, we treat patients selectively, whether it be with a stronger blood thinner like Coumadin or aspirin, and early mobilization depending on their risks. Of course, what we worry about most with any surgery is infection. Fortunately, the risk of infection following a knee replacement in our experience at Concord Orthopaedics and Concord Hospital is quite low, 1% or less over the years. But in that unusual circumstance of an infection occurring, it's a real problem, which is typically a surgical problem where patients need to have further surgery, antibiotics through an IV for a couple months, and often the artificial knee is removed, where patients are left without a functional knee joint for a few months. They need crutches or a walker or maybe a wheelchair for distances. And then if the infection has been treated adequately, then we can go back and put a new knee back in a few months later. The reason for that is the bacteria, they stick to the metal and plastic pieces, so the antibiotics alone, pills, just can't take care of the infection. Things that are more common than that are feelings of stiffness and tightness in the knee. Many patients describe that the knee feels stiff or tight even when it moves well, but usually the best predictor of how someone's knee moves after surgery is how it moved before surgery. So if someone has a knee that doesn't go very straight or doesn't bend very well, they may get improvement in motion, but they may not, but pain is typically more predictably relieved. Usually, as I say, the knee bends and straightens about like it did before, but sometimes it may not straighten or bend quite as well. And there's a rare person who, for whatever reason, forms a lot of scar tissue, which just may bind up the knee to a point where it doesn't move the way it needs to. And in those unusual circumstances, then we may need to consider other things to help move it along. But that's uncommon. It's just very critical with a knee replacement the patient be really invested in their physical therapy the first 4 to 6 weeks. It's going to be stiff, it's going to be tight, it's going to be sore from the surgery, and patients can't be afraid of it. So they're not going to do anything to harm it or damage it. They just need to push through those feelings early on to get off on the right track. And then finally, it's a machine. It's metal and plastic. It wears over time. The odds are favorable for it lasting hopefully a good 10 to 20 years, but sometimes unusual things can happen. And there may be a 1% chance that some strange thing would happen in the first year, requiring the surgery to be redone in the first year. Over 10 years, maybe a 10 or 15% chance, and over 20 years, maybe a 50% chance. So the odds are favorable for a good long time of use. And the final thing is, as with hip replacement, there's no harm coming to a patient not having a knee surgery. So it's not as if we're talking about a leaky heart valve or a sick appendix or a cancer. Patients aren't going to become ill from a sore knee, but on the other hand, it's not going to get any better. The one caveat to that is that we frequently will talk about if patients often will, whether they have an arthritic hip or knee, begin to describe feelings of instability and giving way. And if patients feel like they're going to start falling or do fall because of the pain, in those instances we will encourage patients to intervene sooner as opposed to later, because we don't want them to fall and break their wrist or hit their head or break their hip in those instances. So when patients start to describe feelings of instability or giving way or actually falling, then we will encourage patients to have the surgery sooner as opposed to continuing to wait.